Hello. Good morning, everybody. Okay, we'll be starting in a few seconds. On my watch, it's already 10:15, but I don't know your watches. But we can start in a few seconds because we are still waiting for the another one speaker, and hopefully he or she would be able to come on time. Okay, so just sit back, relax. Okay, and then enjoy the performance rather. Okay, okay, I think we can start now because the more time we spend in the presentation, the better for every one of us. We would be learning a lot from this session. Okay, as I say in our country, I'm from the Philippines. I am Big Chua of the Catholics for Reproductive Health in the Philippines. We say, magandang umaga po. Good morning, everybody. Okay, welcome to this session on faith and family planning. We would be listening and discussing several examples from Kenya, Chad, Niger, and Somalia. So, okay, so we can start now. I decided to stay here in front of you because you know my height. If I stand here, you might not be able to see me. So I'd rather be here if that's okay with you. And I will also be asking our presenters later on to sit in front after their presentation so that you can see them appropriately. So with us, we have four speakers this morning. I will be calling them in accordance with the one listed in the website. I would be introducing them I will be talking about them very shortly, but like for instance, this morning, we would have a presentation from the woman. Okay, it's a woman first, just like our staff support over there. She is called First. Okay, hi First and Metas. They will be our support. Okay, for the first presentation, it would be about the uncelebrated champions. Religious leaders play a role in family planning access and uptake, a case of DESIP program in Kenya. She is the SRHR technical lead of the Faith to Action Network. My friends and colleagues, please welcome Mariah Tureri.
Hello, everyone. Yeah, so this is Maria Torore from Faith to Action Network, and welcome to this session. Big, I believe I have not more than how many minutes? Not more than 15 minutes. Okay. So as Big has introduced me, I'm the SRHR technical lead for Faith to Action Network. Faith to Action Network is an interfaith network of about 110 members spread all over globally. We are in 34 countries in Africa, Asia, Europe, and the Americas. Our headquarters is in Nairobi, Kenya. And our vision is a world in which interfaith collaborations advance healthy, inclusive, just, and peaceful communities. Our mission is to mobilize faith actors for interfaith dialogue and collaboration to advance family health and well-being where SRHR falls. We also advance women's rights and gender justice. We also advance peaceful, just, and inclusive communities. And for this session, I'll be presenting about one of our projects, as Big has said, DESIP, which stands for Delivering Equitable and Sustainable Increases in Family Planning. So Faith to Action Network in that consortium was providing faith-driven, client-centered demand creation and service delivery for family planning. We've been implementing this project in Kenya, and we have contributed to Kenya's 2030 commitments, which include to increase modern contraceptive prevalence, MCPR, from 61% to 66% by 2030, increase CPR for contraceptive method among adolescent women from 40% to 55%, reduce adolescent pregnancies among women aged 15 to 19, again that's the adolescents, from 18% to 12% and to 10% by 2025. And also to broaden access, choice, especially in regions such as northern Kenya. I'm sure by now you're curious to know about how we handled adolescents from the faith-based approaches. And that is what I'll be going into. So northern Kenya is where we have been implementing. And I'll be sharing more about that region. For now, I would like to just allow you to reflect a bit. I believe that many of you ascribe to a certain religion, or you know somebody who ascribes to a certain religion. Just think about it. Religion has an influence on very many areas of our lives. The cultural norms and values, formation and sizes of families, cultural practices. So if religion or faith has an impact on these areas, why can't we utilize faith-based approaches to also influence uptake, acceptance, uptake, and access to family planning? You will agree with me that it is a viable approach, it is a necessary approach, and I will be showing you how. So for this study, it's a retrospective, it was a retrospective study reviewing the period between 2019 and 2021 of the project. Our faith partners include Muslims, Christians, and African traditional religions. We implemented in 9 Kenyan counties with marginalized communities, and the physical characteristics of those communities include high distances or large distances to health facilities, high levels of insecurity, high illiteracy levels, droughts, and for the social cultural characteristics, there is high level of patriarchy, so women have low decision-making power. We have cultural and religious barriers, whether real or perceived. In some cases, you just find that they are not actually real barriers. It's just a belief. Then our primary beneficiaries included poor rural women, adolescents, persons with disabilities. By poor rural women, I mean that they are deep in the rural areas with poor access to information. The health facilities are very far, low decision-making power, and there's that visual cycle of poverty. Intermediary beneficiaries included the faith-based organizations, health service delivery and management teams, as well as the faith leaders. So key results from that project, we were able to train a total of 393 religious leaders to work with other demand creation agents for FP. The other demand creation agents include traditional birth attendants, community health volunteers, and peer educators. These demand creation agents were able to reach 27,855 persons with FP messages. This include men, women, adolescents. We worked in 336 health facilities, provided or supported 2,610 outreaches. And through these service delivery points, we were able to reach 170,236 women of reproductive age, and of them, 10% were adolescents. So to strengthen the health system, because we also work on that, we did service availability and readiness assessments before starting the implementation of the project. We supported reproductive health as well as commodity technical working groups for the local governments. We also supported or did supportive supervision and routine data quality assurance, identified gaps that were existing in those facilities, and provided support to improve on the areas that needed improvement. So what were our CYP achievements? As at the end of year 1, because it was the starting point. We had achieved 78.6% of the CYPs. But as of year 2, we had greatly improved because now we had done a lot of groundwork, a lot of training, supportive supervision, equipping the health facilities, trainings of healthcare workers, and the CYP improved to 105%. Year 3 has also gone, and there was so much more improvement, and we are now in year 4 of that project. So I would like now to talk about the effectiveness of the faith-related action. Yeah? So we used faith-based approaches to SBCC, and obviously we started with mapping the communities, got to understand their characteristics of the different age groups, the men, the women, so that we could tailor the SBCC messages and strategies to the community. And we did this in collaboration with CHVs, traditional birth attendants, and peer educators, and they were supervised by what we call community health assistants. So we work together with the local government. We don't work in isolation, as well as the other partners from the consortium. And then we identified, or we worked with Christian and Muslim theologians who led scripture clarification sessions in relation to family planning. That is how we brought on board the religious leaders. Then we trained the faith leaders, and the trained faith leaders were now able to participate in community dialogues, male engagement forums, couple counseling sessions, radio shows, and to also give or promote FP uptake through places of worship and many other platforms. The faith leaders also participated in advocacy for health system strengthening, and through that, because they are in touch with the actual situation at the ground or in the health facilities in their areas. So we have achieved capacity strengthening for healthcare workers, as well as improved supply of equipment and commodities. So it is important to also listen to faith leaders because they have a lot of feedback from the communities they serve. So our faith advocacy achievements, we have been able to demonstrate innovative interfaith-driven and client-centered approach. So we have demonstrated that the faith leaders are actually willing to participate in promoting health delivery. They are available and they have potential. They have organized structures, a wide reach, and they are highly influential. So this is a cost-effective, highly replicable, and a scalable approach. It is sustainable because faith leaders will always be there in the community, and once trained, they are willing to keep supporting projects and programs that are beneficial for their people. There is also the extra benefit that it is self-sustaining. Those faith leaders who have already been empowered and trained will keep training others or will keep empowering others and getting more and more allies to the program that you're promoting. Then we have also brought faith perspectives to broader SRHR debates and interventions. So now faith leaders are no longer seen as or generalized as opposition. We have been able to show that they are actually allies if brought to the decision-making table on time, but not as an afterthought, so that they participate in designing. They also bring their ideas, and faith leaders are also experts. They are specialists in different areas. So their work is not just to, only preach. They also have a lot of technical input to give. We have opened policy spaces for faith participation. And one of the achievements here is that many of the local government authorities in Kenya have also recognized faith leaders as health champions, not only in FP, but in very many other areas. We have mobilized and capacitated faith-inspired actors on problem solving without advancing partisan ideology. As you notice, our approach was interfaith. We targeted Muslims, Christians, as well as traditional African religions. And we know that many of these problems are cross-cutting. They do not affect only one faith. Yeah? So we try and identify what is the common problem and what are the common solutions. And faith leaders are always willing to support this without, bringing in partisan ideologies, as long as it is beneficial to their people. The approaches might be different, but we're able to agree on the problems and the solutions. So in conclusion, and some recommendations is that it is important to conduct trainings and facilitate scripture clarifications for the faith leaders so that they can be empowered, to support whatever program area that we would like them to support. And they are willing to utilize their religious platforms. Another recommendation and conclusion is that unified interfaith voices are able to achieve a lot. So when using the faith-based approaches, bring together faith leaders from different faiths, empower them, facilitate them to be able to join their voices together so that they can be stronger. We know that voices are stronger, can be amplified better when there is a joint approach. Then we should also support faith actors to be able to demonstrate their evidence. There is this common observation that faith leaders or faith actors do a lot, but what is lacking is the evidence to showcase what they're able to achieve. But through such programs and through our program in DESIP, you've seen me presenting data. We have been able to show through data what the faith community can achieve. So we need to keep facilitating that and using it in such forums, such as the ICFP. Thank you very much for listening to me. I can share more. Feel free to reach me through that address. Thank you.
Muchas gracias, Maria. Thank you so much. Now, as we move from Kenya, we move to Chad. We would be listening on the role of Muslim leaders in family planning in Chad. Let us all welcome Dr. Sinen Hunton, UNFPA representative in Chad.
Good morning. I can't hear you. Good morning. Excellent. Thank you very much. Just like my sister, I will be talking about the contribution of faith leaders in Burkina Faso, Chad. Why Burkina Faso? I worked in Burkina Faso before for 7 years, and I don't know. I think I'm attached to this country. Chad is one of the countries in the Sahel region, and if you know Chad, is 50% is almost a desert country. The majority is Muslim. The population is around 17 million. But what is important related to the subject that we are talking about today is that 2 out of 3 women are married before the age of 18. And actually, when you look at pregnancies, 1 out of 2 girls have had their first child by the age of 16. So maternal mortality is high, as you can imagine. In fact, when you look at the maternal, you break down the numbers of maternal death, 60% of our maternal death are within that age bracket of adolescent. And so beside that, we might be asking the questions, why our girls are dying of child mortality. And I've mentioned the child marriage, but the prevalence, contraceptive prevalence is very low. As we all know, just by using contraception effectively, we can avert 30% of the maternal mortality. And if you look at where we are now with contraceptive prevalence, all method included, is around 8. But when you look at the modern method, we are still hovering around 5.9. But that's not the problem. You need to be looking at trend, because 15 years ago, we were almost at 1. And I remember vividly, I was working on that subject. I was at UNFPA, and we were asking ourselves if it was worth even investing in that context. School drop is 30% for primary school. So education has something to do with maternal death. Institutional birth is 40%, but the quality is still less desirable. So this is pretty much why girls are dying more of maternal mortality in Chad. But when it comes to the issue of family planning, if you look at the supply and the demand, we did make the conscious decision that we need to invest in Chad. So Chad has been a priority country for the UNFPA supply, the global facility to fund contraception, and we've been doing that ever since. But what we have noticed is what my sister alluded to about some of the barriers that we had with, from the faith organization. Beside the cultural aspect that there is a desire to have large families, but also a peer pressure. Because if you are an adolescent girl in Chad and you are not married and you are going to school, there is that sense that you might be promiscuous instead of being in a marriage. So we have that context to deal with to be able to increase the demand. And so we figure out that as much as we need to be investing in supply chain, get the product out there for the women and family to use them, we need to deal with the barriers that we are having with the faith leader. And so what we've done over the years is engage them and to make sure that at least they are no longer a barrier to use family planning. We've held a very large conference about Islam and family welfare in 2017. And before that, we have been engaging the Higher Council of Islamic Affairs and other interfaith organizations. And I might say that it has been very positive. Today, we are no longer having that barrier expressed by the imam in the madrasa of using contraception. We've developed South-South cooperation with the faith leaders. We've taken them to Egypt, to Bangladesh, to Indonesia, and it has been extremely helpful in changing the narrative from the faith leaders. And we have advocates, you call them champion. We have them, like over 600 of them across all of the provinces. And most importantly, we have the female preachers because we realize that for women to go to community, no, to go to community, you have to be a woman if you want to talk to the women. In fact, we have difficulties when we post gynecologists that are male to examine female. So we decided to invest in what we call the female preachers, and we have a network of 6,000 of them now. So this is an army that we can positively use to impact household in Chad. And we've been doing that through the Quranic school as well. So what have we observed so far? We've observed a positive return on that investment. In fact, if you look at, for example, comprehensive sexuality education, where we have pushback in various corners of the globe, Chad is in a shining example where we have been able to have a comprehensive sexuality education curriculum. Is not called that way. We have contextualized the name in Chad and it's called Life Education and Reproductive Health. But if you look at the content, it's very progressive and this is what we really want as a community. That picture there is 4 ministers launching that curriculum and training material, Minister of Youth, Education, Health, and Gender. So this is very positive that we are having. And the person with the turban that you see there is the president of the Higher Council of Islamic Affairs. So they were all there to launch that. Now, we need to pause. And like my sister said, have we seen the number move? If that graph is showing you the trend of TFR over the last 20 years, and also modern prevalence contraceptive, you can see that those dots, blue dots, they have not moved. And there is a reason why they have not moved, because child marriage has not changed. And when you are married off, you need to validate the marriage. So in our clinics where we have the midwives, we are seeing women at 25 years plus. By the time you reach 25 years, you have had 4 children, sometimes 5 children. So that's why the TFR is not moving that much. which is telling us something. As much as we are getting the barrier lift off from the religious leader, we still need to be able to reach those adolescent girls married. The modern contraception has moved a little bit. We are now around the 5.1, like I mentioned. So what is our takeaway from this? Three things. Yes, it is very important to engage faith leaders, and we will have return on investment. It just takes time. In our case in Chad, it took us almost 10 years to be where we are now, where we don't have expressed view against family planning. But that alone will not change the TFR, will not change the dependency ratio, and will certainly, as we've seen in Chad, change the prospect of girls' human capital, because we still have girls out of school, been dropping out of school. I mentioned 30% dropped out of school for even those who have chance to start primary school. We still have 2 out of 3 girls married off. Even the latest mixed survey has shown that. And what that data is telling us, at least one that we are thinking, is that we need to reach those adolescent girls. So what we are thinking is design a specific program that will allow us to use this female preacher I mentioned to be able to reach those households where we have the girl. If they are already married and they have first child, maybe we will be able to delay the second child. Maybe we will be able to get them to start using contraception. So that's where we are as reflection, and we will be happy to hear from other experiences across the world. I must say that as a researcher myself before I joined UNFPA, I've studied this in various countries, Ethiopia, Nigeria, Burkina Faso, and the same trend seems to be going around. So this is what I wanted to share with you, and thank you very much for your attention.
Thank you so much, Dr. Hondan. Okay, I could share also our country experience with regards to teenage pregnancy, but we would listen first to the next speaker um, to talk about expanding access to family planning services through Islamic religious scholars, the Somalia case study. Please welcome the International Rescue Committee Senior Reproductive Health Manager, Mr. Mohammed Yunmis.
uh, as she said, okay. Thank you for introducing. My name is Dr. Mahmoud Abdi Yunis. I'm from the International Rescue Committee Somalia program. I will be presenting expanding access to family planning through Islamic religious scholars in the humanitarian settings. Before I start, let me give you a little bit of background in the country. Over the past 3 decades, my country, Somalia, the health institutions and health systems were not that much strong. And the country's maternal mortality rate is one of the highest in the world. As you can see, it's 632 per 100,000 life parties, as well as unmet need is also very high. Therefore, the Federal Minister of Health of Somalia has 3 strategies in fighting the maternal mortality in the nation. The first strategy was to escalate or to increase the number of skilled birth attendants. And the second strategy was to increase the number of CMOC centers. And the third strategy was to increase participating or family planning services so that women can have at least can space their parties so that we can save lives. And that was the entry point that IRC has came to implement a family planning project. And in early 2019, IRC has started to implement a family planning project, and thanks to FCDO funded project, the Wish to Action project. And in 100% Muslim country, family planning implementation was a little bit so sensitive. You cannot talk about family planning openly, and the mites and misinterpretations as well as taboos surrounding to family planning were extremely so high, and women cannot accept family planning services easily. Some of them, they believe that family planning services will lead them to infertility. Some of them, they believe that the side effects of family planning might cause infertility, while others, they believe family planning program as a Western program that's being designed to reduce their children. So the mites and taboos surrounding the family planning implementation was extremely so sensitive. And IRC has started to implement this project. First, we have tried to train community health workers who are more closely to the communities. And we have conducted a robust community-based activities in our settings. And that was not working well since from 2019 up to early parts of 2020. There was stagnant and it was not working well. And that is the point where we came to also introduce religious scholars. And as some of you may know, religious scholars are the most influential entity in our context or in majority of the Muslim nations. And their words are being heard better than any other groups. Therefore, with the help of the Federal Ministry of Health of Somalia, we have engaged a group of religious scholars. They are called National Islamic Advisory Group. And when we engaged, we firstly trained them, the religious scholars. We have provided some sort of SRH training, and after that, they have also developed key messages on religious, key messages of SRH perspective, from religious perspective. And then we have integrated religious scholars into our community-based activities. After we have trained the religious leaders, we have integrated all the community-based activities. For example, we used to conduct outreach campaigns, community dialogue session with disability groups, and all those kind of community-based activities were integrated religious scholars. So religious scholars will come whenever there is a gathering of communities. They will also give some key messages regarding on SRH messages from the perspective of Islam. And the strategy was designed to inform as well as to involve and empower Islamic religious scholars to promote positive attributes with regard to the questions of religious acceptability of contraception, to increase FP utilization, family planning utilization. And as I said earlier, the unmet need was very high. And I remember even when we were training the religious scholars, even the religious scholars themselves, they needed the family planning service, but they didn't know where they can get. I still remember that when I was training the religious scholars, one of the religious scholars raised his hand and he said, my 20-year-old granddaughter is being operated for cesarean section. She's now in hospital, and I don't know where I can get. He knows some private hospitals, but he cannot afford to take family planning from private hospitals. It's almost $100 per one implant, 3-year implant. So he said, where I can get. So I just tell him the next hospital, which was public hospital, where IRC was operating, is available. So even the religious scholars, they were not able to get, they were not knowing where they can get family planning services. And from that point and onwards, even they have promised to us they will bridge family planning and SRH messages during the Friday gatherings, in Fridays prayers, where all the people came to mosque, then they will lecture and they will provide free SRH services and where they can get. So as I said, the methodology was to train Islamic religious scholars, and then Islamic religious scholars were integrated to the community-based activities, and then they will provide key messages on SRH or family planning from the perspective of Islam. And later on, even we have also got some surprises after we have introduced the religious scholars. Initially in 2019 and in 2020, our data was not going well. The number of clients who were utilizing were very less, and we were like, what are we going to do next? So after we introduced the religious scholars, we found out that things have changed dramatically, and the number of clients who were coming to the clinics were very high, and surprisingly, our data was like this. As you can see, in this yellow part, it was the first quarters of 2019, this per quarter, and these numbers are CYB, cavalier protection. As you can see, this also red calf, black calf is, it was after we have introduced it, the religious scholars into our community-based activities. So it has changed, the data has dramatically increased, and initially it was like 650 CYPs per month. But later on we found out that our monthly average of CYPs were like 3,500 CYPs after the intervention of integration of religious Islamic scholars. And this is how also, sorry. This is the client exit interviews that we have conducted after the introduction of religious scholars. And from the first client exit interview, it has increased to 71%, and later on it has also gone to 89%. What we have also realized was that what the number of clients that the type of clients you are getting were also very high compared to first-time users compared to repeat users. So first-time users also increased after the introduction of religious Islamic scholars. Lesson learned. Lessons, we have introduction of or using Islamic religious scholars as part of implementing family planning programs or as whole SRH programs has worked well. It's also critical that SPCC message is considered to be tailored to religious concerns. So even SBCC messages needed some kind of modification. SRH messages based on Islamic, basic from the perspective of Islam is also key, and people understand better. And the other one is integration of Islamic religious scholars into the existing community-based structures like community health workers were integrated into the family planning programs. So it has worked well. And that's all I can say. Thank you so much.
Okay, thank you so much, Mr. Mohammed Yunis. Okay, we have heard from the 3 program implementation, and the message is very clear that we need to engage religious leaders if we need to increase the uptake of family planning, if we need to prevent or probably lower teenage pregnancy, if we need to improve maternal health, and consequently, children's child health as well. So we have listened to the 3 presenters. I would like to ask if Abramani Birth is here. Okay, if he's not, but we still have until 11:35, I suppose. So we have time for discussion, but before that, I would like to invite the presenters to sit in front. Maria Chorere, please sit in front. Dr. Dr. Hunton and Mr. Yonis, please join. I would like to stand up, but it does not seem you like to join together. Okay, you don't want to sit here. Okay, it's okay. I was just joking, Mr. Yunis. Okay, so we have lots of time. So do we have some questions? And when you ask questions, please mention your name and your organization and your question and comment very briefly. Okay, do we have hands? Okay, so look over there, ma'am, and then Kathy. Okay, so I'll start with Luke, please. You can have this.
I'm a friend from IRC. Sorry, I don't know your name. I missed it. Eunice? Eunice. Thank you. So I am Luke, and I work for THUR Fund, which is a Christian development organization. So we work a lot with faith communities, and we know that trust is a big part of that. And some of the trust that we get is because we are a faith-based organization. I'd like to know your experience of that entry point with faith communities, given your different positionality. What's worked well for you, and what challenges have you faced with entering faith communities?
Okay, sir. Thank you, Luke. Please.
Thank you. Even from our perspective in the Somalia country, initially we have overlooked to work with Islamic religious scholars, and we have tried to be more focused on community health workers and the likes. But later on, we found out that it's not working well along with the community health workers and the other strategies. But what we found out was that, for example, in the case of Somalia, religious scholars are more influential than any other groups. Let me say political leaders and any other groups. Their words are heard better more than any other group. So that's why we introduced the religious Islamic scholars, and whenever communities, whenever we have gatherings or let me say community-based activities where we gather a large group of people, as a medical doctor or as a midwife or as any other person, if you go and tell them whatever you like, they might not hear well. They will show you as as someone who is working as, let me say, international organization or local organization. But when you include that group or when you bring a religious scholar, by the moment they saw the religious scholar, they will start believing. So, and those kind of projects like family planning, initially people believe that it's like, for example, it's like a Western project, and they believe, particularly in my context, they believe that it's something like to control path. But when they saw the religious scholars there, definitely they will change their mind. And that was what working well. Maybe there are challenges because, for example, there are different sects, particularly in the Islamic religion. So some of the sects, there are sections, different school of thoughts in the Islamic religion. So maybe there may be variations or challenges when you go, but it depends on the group you are working with. So in the Federal Ministry of Health of Somalia, there is already a group, they are called the National Islamic Advisory Group. So whenever the Federal Ministry of Health finds a sensitive program, for example, in the immunization programs, it was also difficult in some times back, let me say 10 years back or 5 years back, it was some way difficult. And people, they don't believe immunization. So when such time comes, the Ministry of Health will call the religious scholars, the National Islamic Advisory Group, so they will give their lectures, they will provide their key messages from Islamic perspective, and that's when people are will believe.
Okay, thank you, Mohammed. That's very enlightening. To spice and to liven up a little bit, I will get two more questions, ma'am, and then Kathy, and then another round. Yes, ma'am.
Thank you so much. My name is Katharina Hinz. I'm from the Berlin Institute for Population and Development, and we've done a recent study on how religious organizations can facilitate demographic change in Africa. And if you are interested, I have some copies left, I mean, of the summary. But my first question, I have two questions, very short, if I may. I have one question to Maria. You have told us about your interventions in northern Kenya. And I would like to know, how do you do that? If you enter a community, what do you do first? How do you convince religious actors to be part of this program? What is your approach there? Can you give a practical example how you involve them in the first place? How you convince them that they have to be a part of that? And the other question is to you, Senan. You've told us that there is still a problem about child marriage and also school dropouts. And you told us that you have involved several ministries in this effort. Why didn't you get on the Ministry of Justice? Why couldn't you convince the stakeholders that the laws that must be there are enforced somehow? Why couldn't you involve them? Or you said that the Ministry of Education was part of your efforts. Why weren't you able with the program also to make sure that girls stay in school? Simple questions. Thank you.
Great questions, but before you answer that one, can we listen to another question from Kathy, please?
Thank you. I'm Kathy Erb from Christian Connections for International Health, and it's great to see this topic. My question is for Dr. Hutan about the female preachers, and I assume that's an English translation of the phrasing you used. And I'm curious if there was much pushback about women taking this role or how they were received in the Islamic community.
Okay, thank you so much. So we can now give the floor to the woman first, Mariah, and then to Dr. Hutan. Mariah.
Thank you very much, Catalina, for that question. So yes, we are implementing in northern Kenya, and your question was about probably our entry points and how we got accepted to even start that discussion there. So first is to work through umbrella bodies, yeah? So for example, Northern Kenya is predominantly Muslim, and we have the Supreme Council of Kenyan Muslims body, which is an umbrella body for the Muslim religious leaders. So first we approached them, and they helped us identify the national scholars we could work with. So those scholars and theologians are the ones who are very useful when it came to approaching the leaders in northern Kenya. Another approach was during the baseline evaluation, we were working with the local leaders. The local community were part of it. So even them, they were able to see data, the data about the situation in their region. So our approach as Faith to Action Network is to combine scientific evidence as well as scripture-backed strategies. So through working with the data from the baseline evaluation and working with the national scholars and the umbrella bodies, we were able to compare what the scriptures say with the interventions that we were also proposing or that also came from them. Yeah? So it became easier to now come up with specific interventions that are relevant for that region. The other strategy when it came to the program staff was to work with people from those localities. So the program coordinators and the officers are all from that region. So they understand the cultural and the religious context. So I would say those are the three main strategies we used. So it has to be scripture-backed. Thank you very much.
Thank you very much. Katrina, you asked a very, very important question. But like anything else, in Chad, we are still very far in terms of upholding the law. We have a good law on paper, but those who are supposed to uphold the law are actually the one encouraging the practice of child marriage by marrying themselves, adolescent girl, and by, I would say, normalizing it. So, but this is the next frontier. And in fact, with the United Nations agencies and other organizations, we are for the first time putting one-stop centers in the countries. So the legal aspect, we are working on that. But this is definitely the next things to do. For Kafir, yes, there is no pushback. Chad context, they are very progressive, I must say, when I compare to other Muslim countries. So female can preach. In fact, it is under the umbrella of the higher Council of Islamic Affairs. In French, is Conseil supérieur des affaires islamiques. And like you said, the translation is femme prédicatrice. So they do preach, female do preach. And so that's why we are using that unique opportunity that we have in Chad to use them actually as community-based health workers and to be able to enter the household because they are allowed to speak to the women. So no pushback on that at all. Thank you.
Okay, thank you. Now we can have another round of questions. I have three hands. Sir, you, and then ma'am, and then ma'am over there. So three, can you please give here, and then Sik later after. Okay, sir.
Hello, good morning, and thank you for the presentation. I am Ibrahim Balami. I'm from International Rescue Committee, and I come from Northeast Nigeria. I have two questions, and the first is after the training of these religious scholars, how do you follow up to see the quality of the message they pass to these people, and also checkmating personal bias in terms of the method people take? Because one case we saw in our location is that oftentimes there's still a challenge in the uptake of long-acting reversible contraceptive methods. So that is a big one. It's also the bias. It's not just for them, but even among service providers. Then the second question I have is the problem with family planning. Oftentimes in my context, it's not the woman, it is the men actually. And so how do you address the issue of unhealthy competition among women? Because in polygamous family, oftentimes they believe that the number of the children the woman has determines how much she gets as an inheritance when the man dies. So the competition for childbearing is always there. Thank you.
Okay, the very interesting question. Please hold on to your answer. We will listen to the second one. Please. Uh, uh, the lady and then Sheik after.
Okay.
You're the second after the lady over there. Yes, ma'am.
Okay, thank you. Irene de Vries from Kid Roy Tropical Institute in the Netherlands. Thank you for very insightful presentations. My question related to the matter of safe abortion. I haven't heard the topic yet. In all the free countries, abortion is legally allowed under certain conditions. But I think the access is still very low, yet the mortality as a result of unsafe abortion very high. So I was curious if you had any experiences with religious leader addressing this topic. Thank you.
Okay, now it gets warmer as we go into highly contested issues, women competition, now safe abortion. Yes, madam.
Hi, I'm Jamila Asker. I'm a student at Johns Hopkins University. And I know you guys mentioned that in Somalia, the proportion of child marriage is at 45, while also in Chad that you said 50% of girls are being married at the age of 16. So my question is kind of focused on the faith leaders. How have they addressed youth as couples and these issues? Because sometimes youth services are not for youth, even though it's for youth. And I'm just trying to figure out how have you equipped religious leaders to address that, particularly for you. Thank you.
Okay, thank you. And allow me to give the mic to my good friend Sheikh Selu.
Thank you very much, Big Big. Mine goes to the brother, UNFP representative in Chad. I'm involved in the SWED project in Senegal. And I know that the SWED project, the involvement of religious leaders in the SWED project was initiated in Chad back in 2017, I think, or thereby, anyway, where a big conference was held that gathered over, I can't remember the number of religious leaders, but you know. So it is about, the SWED project is about the realization of demographic dividend with a big focus on, on family planning and also, you know, girls' education. So I just, my question is, your assessment of the impact of the religious leaders in Chad in the program so that we can be inspired, you know, for our program in Senegal. Thank you.
Okay, now we're nearly closing, so I would like to have this special request to our presenters to have very brief, concise answers. So we start with Dr. Houghton, please.
All right. Let me start with the last question. Yes, I actually referenced that in my presentation. That conference was in 2017, over 1,000. It was an Africa conference really on religious leaders. The impact of the religious leaders on the SWOT program, that's what I summarized, that the narrative is not against the use of family, is no longer against the use of family planning. So that's very positive. The narrative from the religious leaders is to encourage girls' education. But there is a but there. It's mainly the primary school. Because they have not firmly said that girls should not be married off. And because child marriage remains there, they literally take girls out of school to go into marriages. So we have not reached that aspect. That's why I think reflecting on that, and if you want to look in the context of Senegal, the female preacher is the like of the Bajengo in Senegal. And so they can you can use them so that they can enter the household and affect maybe delaying the second pregnancy. On the religious level, they have addressed youth. This is where we still have to make progress, because our agreement is that they won't be against child marriage. But some of them will tell you that they can still marry but not consume the marriage until the girls reaches 18, which is not what we have been observing. So when they go public, they won't talk about that, at least at our event. When we invite them, they won't be making this type of claim. But overall, I think we have them as ally. And lastly, on the unsafe abortion, no, we don't have experience in Chad on that.
Okay, thank you, Dr. Hotan. Maria, please.
Thank you very much for your questions. I will start with one on how we assure or ensure quality of messages. So after the training of religious leaders, they're the ones who come up with the messages or messaging to promote family planning. For example, in northern Kenya, they chose that instead of calling it family planning, to make it more acceptable, they would call it child spacing, so that they know that it's not about, communities understand that it's not about limiting the number of their children, but ensuring healthy timing and spacing of pregnancies for the health of the child, the mother, and the family and the community at large. So to support that, we have regular meetings for the faith leaders. So we support like quarterly sensitization meetings where they share their experiences as well as strategies. So in these sharing sessions, we are able to ensure that the quality, the accuracy and consistency of correct messages remains the same. So in those meetings, they are also always inviting some new faith leaders into the fold. And these new ones are also sensitized, and the network of faith leaders who are promoting family planning expands. Also, these faith leaders participate in referrals. So as they go around creating awareness and promoting family planning, they have tools that they use for referring the women who would like family planning methods, or families, couples who would like family planning methods, to the health facilities. And our program staff follow up on those referrals to check on completion rates and also the methods that were taken up. Somebody asked about long-acting family planning methods, if they were being taken up based on the support from the religious leaders. So yes, the religious leaders are also supporting and promoting uptake of long-term family planning methods, and that is followed up at the facility level to check on completion rates. How to reach the youth? We have very many strategies. I'll just give an example of the mother-to-mother support groups. So these are based at the health facility level. And if you go to that region at the MNCH clinics, maternal, newborn, and child health clinics, most of the women coming in are young mothers. And after they get their services or before, they are usually mother-to-mother support group sessions where you have those who have been taking up methods, influencing or sharing about their experiences, and in the process they influence new uptakes. And then on about competition, so those regions, there are several challenges or practices that honestly affect SRH or reproductive health. There's FGM, there's early marriages, there's polygamy, and we know that after FGM, the girls feel ready to get married and to start their families. But what we do, we also have male involvement sessions, targeting different age groups of the men. At times we target the young men, the older men. We call them we invite them according to their, let's say, age sets, where they can easily share, and they also support family planning. So even the men are involved in ensuring that there is spacing. So let me not go on because we have a lot of information, but in the interest of time, I will just stop there.
Thank you, Mariah. So we'll have a short message answer from Muhammad, please. Short.
Yeah.
I'm sorry.
I will just add one point about the male involvement. IRC Somalia has conducted a number of male community dialogue sessions, and what we have experienced was that males are more lenient when it comes to reproductive health issues of their wives. So they will accept easily when you provide SRH messages related to their wives or SRH messages. They will accept easier. That's some experience in IRC Somali program. Thank you.
Thank you, Mohammed. We're running out of time. I know we're over time, but we have a grace period. I would like to think that we have about 5 minutes. So thank you very much, our presenters. There are actually many and diverse approaches depending on the context of the countries. And there are some contentious, I say contentious because we haven't had that a lot of conversations on those issues as well, but we are slowly getting there. We know for a fact that in order to improve family planning uptake, we need to engage religious leaders as one of the very influential agency and institution of culture. So with that, we would like to thank Mariah Toreri from Faith to Action Network, Doc, yes, Dr. Sinen Huton of UNFPA, Chad, and Mr. Mohammed Jonis. Thank you so much. Yes, everybody, you are free to approach them for other concerns and questions that you have failed to ask. So with that, magandang umaga. But before you go, this is a faith subcommittee session. As we always make it as a tradition before we go, can we have some sort of a prayer, some sort of a blessing before we all leave this room? So join me in praying. Can we all stand? Okay, very. Oh dear God, creator of all universe and humanity, our world is vast and was created in harmony, and yet our global community is becoming fragile and fragmented with the needs of many of our brothers and sisters. Their needs amidst a global pandemic, climate change, of inequality and inequity. O God of injustice and misery, all the barriers that prevent us from realizing your promise to us that we may live our full potentials and with dignity. The challenges are daunting. Guide us through the path of solidarity, of unity, of cooperation as we navigate our mission to improve the quality of life of everyone, particularly the poor, marginalized, oppressed, and exploited, of women and children, of people from diverse genders and sexuality. Give us the wisdom, the courage, the conviction, and to remain steadfast in our mission of planning our lives, planning our families, to live as you have planned for us, to live with full potentials and dignity. As Saint Irenaeus said, glory to God is the living person. Gloria inem Dei vivens, vita autem homines visio Dei. We are not only because of physical life, but especially because our lives consist in the vision of God, and to see God is to be transfigured in Him. We shall all be like Him. So go in peace and remember of our mission to improve each other's lives. Good morning, everybody. Blessings.